Hello and welcome to the CCO Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we explore the current Mpox outbreak. Who is it affecting? What is the burden? And what can we do about it as healthcare providers? To learn about the basics of Mpox, see the link to our accompanying text module in the show notes. And to get access to all of our podcasts, subscribe to the CCO Infectious Disease channel on your favorite podcast service. Today, I'm joined by Dr. Carlos Del Rio from Emory University School of Medicine in Atlanta and Dr. Aniruddha Hazra from University of Chicago. So let's start our discussion. The current worldwide Mpox outbreak began in 2022 and it's still continuing in 2024. Dr. Aniruddha Hazra, why is Mpox relevant to clinical practice?
When we think about sort of what exactly is Mpox, we know that it's closely related to a few other pox viruses like smallpox or variola and vaccinia, which is used for the smallpox virus, as well as cowpox. I think what we're trying to better understand is how does the progression of illness specifically with Mpox in this current outbreak maybe similar or different with past outbreaks or with other members of the orthopox virus family?
Well, and the other thing is, when I think about smallpox, which most of us have never seen, have read about it, but we've never seen because we've been able to eradicate that disease. Smallpox was just a disease of humans, right? There was no infection of animals. Mpox is a disease of animals in which the humans are sort of incidental hosts. So the disease is mostly a disease of small rodents and small animals like that. And then humans become incidental hosts. But here what we're seeing is human-to-human transmission. Again, and a lot of the human-to-human transmission associated with sexual contact. So again, a very different kind of Mpox than what we've seen in the past. When you read a little bit more, all of us, or at least I was impressed that it turns out maybe this wasn't that new after all, that we had seen in some countries in Africa, notably, I think in Nigeria, they have been since 2017, there have been cases primarily among young men and presenting with genital lesions. So in endemic countries, this was something that wasn't new and that had been identified, but I don't think we were paying attention. And by not paying attention, we lost an opportunity to do more work on it. And I think it really emphasizes why we need to be paying attention. What happens anywhere should be a concern for all of us, regardless of where we are.
Exactly. I think, traditionally what we thought classically was Mpox, affecting households or close contact in terms of, children or whatnot. And that was really different from what we saw with this current outbreak. But you're absolutely right, Carlos. This was something that was actually bubbling under the surface and that was already identified in parts of West Africa, including Nigeria, showing that there was clear human-to-human transmission through potential sexual contact much earlier prior to the 2022 global outbreak.
Yeah, no, it was really very different. I mean, this was, again, something that we were not, that caught us, all of us, by surprise, right? There were cases among adults, mostly men, and men have sex with men, mostly men, and all reporting close physical contact with somebody who had lesions. And frequently, almost 50% of them, people living with HIV. So again, it's a very different disease, but we cannot forget that this was, at the same time, there was ongoing transmission in what we call endemic countries and in Africa, and we were not paying attention to that. And I think it really emphasizes why, had we been paying attention, had we been studying vaccines, had we been studying treatments, I think we would have been caught off guard. So it really, I think it's an important lesson for all of us that we need to not disengage from the global situation, because the global situation, it's important to us in the US, in Europe, and other countries.
So what's the impact of Mpox on people who have it? How is the impact in the current outbreak different from past outbreaks?
So when we think about who's at highest risk of Mpox during this current 2022 outbreak, it is really a man, and specifically men who have sex with men who have multiple partners. Those are at highest risk of Mpox. And, close to over 90% of the cases have been among men and men who have sex with men. So that really is a higher risk. That doesn't mean that you don't see cases in women. You do, but they're small. And you also can see occasionally cases in children. Now, that's a little different than what happens in Africa, right? In Africa, most cases have been among children under 15 years of age. But outside of Africa, it appears to be more common in men who have sex with men. So really is different depending on what the setting is and what the transmission dynamics are.
Yeah, and I think what we're noticing with this current outbreak has been really the close, sustained, direct contact with lesions, which really equates to person-to-person transmission. So not just casual contact, not just being around someone in some sort of setting, but it's really prolonged close contact with potential lesions or skin rashes that someone may have who has Mpox as a way to transmit it to others.
Yeah, and I think that's really important, right? That it's really is that sustained contact with infected lesions that leads to transmission. So living with somebody or just casual contact is not necessarily how this disease is going to spread.
Yeah, because there's a lot of concerns about, oh, if I'm at an outdoor festival and someone has Mpox, can I get it? And just having just that type of short-term contact with someone and whatnot, that's not really how we see at least Mpox been transmitted in this outbreak for the past 2 years now.
So I remember, when we start seeing these patients, lots of anxiety occurring and very painful lesions. A colleague of mine at our HIV clinic said, I had never seen adults cry like this. They were very painful lesions. And again, a clinical presentation that was very, I would say, somewhat different than the presentation of what many of us would call, classic Mpox, right? Classic Mpox will present with a prodrome characterized by fever, malaise, headaches, weakness, lymphadenopathy, and then you would develop this rash. And this rash was your typical, macular papular vesicular pustular scabbing, very circumscribed and very specific lesions. And in this case, we were seeing, I would say, a little bit of a different presentation. Many of them, the rash will appear either before, right about the time of the prodrome. Fever was not the most prominent symptom. Only about 60% had fever, but genital rashes, again, were the most common ones. And lymphadenopathy was not prominent. So again, a very different presentation from the classic Mpox. And many genital lesions, when you saw them, it was easy to confuse them with something else, with syphilis, with herpes, with many other viruses.
Yeah. And I think, the classic idea of the prodrome before the rash exactly was sort of challenged by the current outbreak of Mpox. We saw sometimes exactly the rash occur before the prodrome at the same time as the prodrome, or the prodrome persisting for a while even after the rash has developed. And you mentioned the skin lesions, went through a very predictable sort of evolution from macules to papules to vesicles to pustules, which then have potentially scabbed over. And in previous Mpox outbreaks, these were thought to evolve sort of uniformly across, and more of a sort of centrifugal pattern where it would affect the limbs and the torso, but not so, and potentially the palms and soles. But what we saw, like you mentioned, Carlos, was really affecting the anogenital area, and in many folks, the staging not being uniform, that some lesions would be in certain stages and some lesions being in other stages, but still understanding that they would all progress through until becoming pustule lesions that would eventually reepithelize underneath after scabbing off.
The other thing to me that is kind of surprising is, given the fact that there was sexual transmission, there were very few cases in women, right? Less than 4% of the cases globally occurred in women, and very few occurred in pregnant women. Very few of them occurred in children, but over 50% occurred in people living with HIV. And again, most of the mortality was in people with HIV who were not controlled, who did not have, had low CD4 counts, high viral loads. So again, the synergistic HIV made Mpox be almost like an opportunistic infection.
Exactly. Yeah. I mean, I think, the most vulnerable that we found in our clinics and in our experience were people with advanced HIV. So those who were living with HIV but maybe did not have access to treatment. The majority of folks who were impacted by severe Mpox were those that were not on any ART, so profoundly immunocompromised, and those were the ones who were most vulnerable to sort of severe illness related to the virus. And we saw that not only in the US, but in other parts of the globe as well. What we found was really interesting was, while you mentioned, Carlos, that folks would present with anogenital lesions that would be confusing for potential other bacterial or viral sexually transmitted infections, we found a lot of co-transmission occur in our cases. That several sort of case reports and case series noted that nearly up to a third of cases had some sort of co-infection with an STI, like chlamydia, syphilis, herpes, etc. And we definitely saw that in our clinical practice. When someone raised a specter of Mpox, at the same time, it was important to provide sort of comprehensive sexual health services to make sure you're screening them for any other potential STI, including HIV. And that was quite common. We saw co-infections occur throughout the course of the outbreak.
So let's move on of what can we do to prevent this, and what are the things that we need to think about. And the first thing is obviously vaccination, right? Typically, there's a lot of theories that when we used to vaccinate against smallpox routinely and globally, Mpox was not apparent because we were also suppressing it by the immune system. But now that we're not vaccinated, last time we vaccinated people against smallpox was 1973. So most people have not been vaccinated, especially young people have not been vaccinated.
And for the longest time, we only had ACAM 2000, which was, a live attenuated replicating vaccine. And this had a significant amount of side effects and, contraindications in, some populations that really need to get vaccinated, particularly those that were immunocompromised for whatever reason. The MVA-BN or the Jynneos vaccine is a, live attenuated non-replicating or replication competent vaccine and, has been approved for use in the protection of smallpox and has shown good real world evidence of efficacy against Mpox across 2 doses. It is relatively new. So I think it was approved just in 2019, and it has been used regularly among military and folks who have occupational exposure to smallpox. But really, during this outbreak is where we saw a significant amount of uptake in folks for non-occupational exposure, specifically to Mpox.
Yeah, and we saw, the protection was, if you got 1 dose, you got some protection, but maybe 30, 40%, maybe 50% at most. If you got 2 doses, you got much better protection. The best protection is when you got 2 doses. We did all sorts of things to try to vaccinate more people. And I think a lot of our clinics, a lot of sexual health clinics and HIV clinics really did a fantastic job in reaching out to the community. And I think it was a really good effort of a combination of community and public health working together to make this work, right?
Yeah. And I think, really meeting communities where they're at, understanding that communities may not come to a clinic to get vaccinated. So bringing the vaccine to community events was a major part of, the vaccine uptake throughout 2022 and making sure folks came back for that second dose. Carlos, like you mentioned, that efficacy, that, 80 or plus % efficacy we saw was really with only 2 doses. And so it was really important to get folks back for that second dose 4 weeks later. And again, a lot of that was through a lot of the community engagement work. And what was interesting was a lot of that work was really built off of what we learned from the COVID-19 vaccine uptake just a year prior.
I think it'll be really important to discuss, the ACIP recommendations and what we currently are telling people, what are the CDC recommendations, the ACIP recommendations. Yeah, it'll be good to talk about those.
Yeah. So, I think for sure, people at occupational risk of exposure, and that's not a huge portion of the population, but still people that need to understand the benefit of vaccination for them. But specifically what has changed since the 2022 global outbreak is really identifying populations that are vulnerable to Mpox. And that includes gay, bisexual, and other manifested men, as well as transgender and non-binary folks who, based on sexual activity or STI diagnoses, would be considered vulnerable to Mpox. And that includes, diagnosis of an STI or at least one sexual partner, sex at a commercial sex venue, or sex in association with a large public event where Mpox transmission is happening. Anyone that sort of may be meeting this criteria or anticipate meeting this criteria would benefit from Mpox vaccination and should consider it. And while initially, the ACIP had a stringent criteria specifically just at gay, bisexual men, who sex with men who meet this criteria, this is really now thinking about any sexual partners or persons who have sex, again, who have had an STI, have had more than one sexual partner, or sex at a collective sex venue. These are populations that would benefit from Mpox vaccination.
Yeah, and again, as you mentioned previously, we have the Jynneos vaccine, we have the ACAM 2000 vaccine. Both could be effective, but right now there's enough Jynneos vaccine available that there's no reason to use ACAM and 2000, right?
Yeah. And the ACIP actually says ACAM for pre-exposure prophylaxis is only utilized for occupational exposure. For non-occupational exposure, it's MVA-BN or Jynneos that would be the recommended vaccine. So currently for non-occupational pre-exposure prophylaxis, Jynneos is the only approved or recommended vaccine by the ACIP in general. And one thing I do want to say, just like with HIV pre-exposure prophylaxis, someone coming and asking for this type of protection is enough to receive it. That no one has to prove their eligibility or their vulnerability, that if they're asking for an Mpox vaccine, that is enough of a reason to provide it, particularly now that we have adequate supply of the vaccine.
Correct. And again, we need to emphasize to people, to our patients, people who primarily living with HIV or people who are that it's also important to take care of your HIV because you're going to respond better to vaccine if your CD4 count is viral load is suppressed. So this is also an opportunity to re-engage people with HIV who are not engaged in care and talk about the importance of of protecting you, right?
Yeah. And also, like, people who are vulnerable to HIV are also vulnerable to Mpox. So talking about making sure they're getting screened for HIV and potentially even linkage to biomedical interventions for HIV prevention, like PrEP, should all be sort of rolled in. Having this type of syndemic response, I think, is really important because we know that Mpox, HIV, STIs, these don't occur in silos. These are, competing epidemics that are intertwined and impact one another quite intimately.
Yeah, and I don't know. You've seen, I've seen people take the vaccine. It's well tolerated. It really is well tolerated, and the side effects are quite frankly minimal.
I would say, in 2024, we've been able to really provide everyone with subcutaneous vaccination still now because we don't have the same concern of vaccine supply we did 2 years ago.
Yeah, and again, when most people that get the vaccine they may get some redness, some itching in the spot of vaccination, but in general, maybe you get some fever, but in general, it's pretty well tolerated with very few side effects, right?
Exactly. Yeah. So, I mean, people can have an injection site reaction like they would with any other potential vaccine that can be managed conservatively at home itself. But otherwise, the entire MVA, VN, or genius vaccine administration and side effect profile is quite minimal.
The other thing I think is important to tell our patients is that just because you got the vaccine doesn't mean that it works right away, right? It takes about 2 weeks to start having some protection. And sometimes you'll see somebody say, well, I'm traveling to this, I'm going to this vacation and I'm going to this festival and starting tomorrow and I want to get the vaccine. Well, it's not going to protect you, right?
Yeah, exactly. Like any vaccine, it takes a time for your immune system to recognize that and then to develop its own memory and whatnot. So it's, again, going back to making sure that you're getting both doses, and both doses are, a minimum of 4 weeks apart, and really thinking about the, that protection that we think of that's conferred is really 2 weeks after that second dose. And so for folks asking, when am I protected, or when am I, when can Mpox really be prevented in me? It's really waiting 2 weeks after that second dose, which can be up to, essentially 6 weeks from the initiation of the Mpox vaccine series.
So, Dr. Henry, the vaccine is effective to protect people at risk, but can it be used for post-exposure prophylaxis for people who've already been exposed to Mpox?
Early in the outbreak, we were considering post-exposure prophylaxis quite a bit. I wasn't sure, Carlos, if you guys did post-exposure prophylaxis for Mpox, for non-occupational post-exposure prophylaxis, obviously, but some of the indications and the timeline of when folks who maybe, know that they were exposed to Mpox and did not receive vaccination in the past, when they should be considered eligible for post-exposure prophylaxis.
Yeah, no, I think clearly it was an approach that we all followed, the ability to give post-exposure prophylaxis. And you need to consider in anybody who has been exposed and hasn't been vaccinated, it's an opportunity to get them in and get them vaccinated, right?
Right. I think ideally, like any post-exposure prophylaxis, like, the earlier the better, right? So the earlier that they can come in and be given the vaccine after exposure, the better. Really 4 days, I think, is like the time that you really want to get them in terms of the PEP timing. And you have some protection potentially from day 4 to 14. But really beyond 2 weeks after exposure, the benefit or the efficacy of post-exposure prophylaxis with Jynneos is just not really known. And really,
and I agree. But again, I'm thinking that sometimes if somebody is a little bit what we talked before, you may not get any benefit from exposure, from the post-exposure prophylaxis, but you get the benefit of the person being vaccinated, right?
Of course, exactly.
And you need to look at it as an opportunity to vaccinate rather than anything else.
Yeah. And even sort of, data out of New York City found that even these folks that were, delayed or had late post-exposure prophylaxis, they still saw some effectiveness and likely from the ability of protecting them from future exposures to Mpox now that they are fully vaccinated.
No, absolutely. I think that's for sure the case. And I think that's something that we need to remind ourselves over and over that there's still a significant number of people who would benefit from vaccination, and we should get them vaccinated.
Well, thank you to Dr. Del Rio and to Dr. Hazra, and thank you to our listeners for joining in. You can learn more about Mpox at the CCO website. Just click on the link in the show notes. Thanks again, and we'll see you on the next webinar soon.